All right, I think we're ready to get started as people are slowly coming in. It seems like it's leveled off a little bit. But thank you everyone for joining today. My name is Grace Mannix, and I'm a senior project manager on the reporting and analytics team at CRISP. I am joined by my colleagues, Morgan Henderson from Hilltop and Audrey Speeder from H-Metrics, and they will be presenting later on today too on the different reports. For some housekeeping items, this webinar is recorded. We will distribute the slide deck and the recording to all the attendees. We muted all the audio lines to avoid distractions during our presentation. If you have any questions while we're presenting, feel free to use the Zoom chat box, and we'll answer any questions at the end if we have time. If we don't get to your questions, we will be reaching out. So this is our agenda today. We'll start with giving a high-level background of the multi-payer reporting suite. I'll hand it over to Hilltop to give an in-depth overview of the prediction tools, and then we'll hand it over to H-Metrics to go through the prediction tool and quality reports in multi-payer. And then at the end, we'll have questions. So I just wanted to provide some background. So CRISP, in partnership with H-Metrics, worked with Maryland and the Maryland Primary Care Program, MDPCP, and Maryland Medicaid to develop the multi-payer reporting suite. So the multi-payer reporting suite combines the Medicare and Medicaid claims data within a single suite. So you're able to see Medicare and Medicaid claims data for patients on a panel, on your organization's panel, which we'll go through in a second. And so we developed this report for the Maryland Medicaid and MDPCP alignment, and for organizations to be able to track and understand trends in hospital utilization, facilitate care coordination, and monitor population health across their Medicare and Medicaid beneficiaries. So this slide just goes through the data in the report. So this suite displays the following data for patients on an organization's panel. Is the Medicare fee for service, Medicaid fee for service, and then the Medicaid managed care. So those are all, that's the data that's presented in this report. It is all care settings and services. It's all care settings and includes any services covered under Medicare and Medicaid. And we display the last 36 months of data, but keep in mind there's about a 2-month data lag just because this is Medicare and Medicaid claims data. So going back about the data some more, this diagram just shows what is included in the report. So in order to use this report, first off, you have to have a panel set up with CRISP. So your organization needs to have a panel with CRISP. And a panel is just basically a list of patients you submit to CRISP saying you have a treatment relationship. Once you have that panel set up with CRISP, we're able to provide access to that panel for you to access it in the multi-payer reporting suite in CRISP reporting services. And so in this report, you're able to see the Medicare fee for service, the Medicaid fee for service, and the Medicaid managed care beneficiaries for patients on your panel. If the patient is not enrolled in Medicare or Medicaid, they will not appear in this report. And if the patient is not on your organization's panel, they will not be in this report either. If you have any questions about panels, setting up a panel, anything, please reach out to support@crisphealth.org. The email's at the bottom of the slide here. And so here, this slide just goes through accessing the multi-payer reporting suite. So it's available in CRS, and you can find it under the all-payer population card. And here I have it highlighted, the all-payer population card, and then where you'll find the report. And so if you do not have access to CRS, or if you don't have access to this report, please reach out to report-support@crisphealth.org. This is the CRS support email, so we're able to help you here, and we can assist you in getting you access. And so today we wanted to go through some of the new reports that we've released since October. So we've released 2 reports on quality measures, the quality measure dashboard, and then we have the health equity by demographics for the quality measures. And then we also released a report in February, so this month, on the prediction tools. So being able to see different prediction scores for your patients on your panel that fall into that Medicare and Medicaid population. So these 3 new reports were just recently added. And so today we just wanted to go over these reports and help you walk through them so you're able to utilize them. And I will hand it over to Morgan from Hilltop. Thank you, everyone.
Thanks very much, Grace. Is my audio okay?
Yes.
Perfect. Hello, everyone. Thank you very much for having me on. My name is Morgan Henderson. I'm the Director of Analytics and Research at the Hilltop Institute at UMBC, and I'm part of the team that make these risk scores, which is the same team that actually has been making the MD-PCP prediction tool risk scores for several years now. And so here to give you an overview of the scores, and happy to answer any questions. Just pop them in the chat, or we can follow up offline afterwards. Next slide, please. So Hilltop has several models currently in production, and the 2 models that are now in the prediction tools report in the CRISP multi-payer reporting suite are the pre-AH, so the predictive model for avoidable hospitalizations, and the pre-DC, so the predictive model for type 2 diabetes complications. So there's now 2 separate risk scores that are available in the prediction tools report. Next slide, please. So these risk scores, that they're both risk scores are built on the same underlying structure, which uses administrative claims data. So either Medicare fee-for-service claims or Medicaid claims and encounters. And so these administrative data, they comprise all the sites of care, pharmacy, inpatient, outpatient, professional, and beneficiary demographic information. And we also include a very rich library of publicly available environmental social determinants of health data, which we assemble from a variety of different sources. So think things like local poverty rates, or the rates, the fraction of individuals over age 65, things like that. Next slide, please. Each model has a very rich set of risk factors in it. These risk factors comprise 5 different domains. So there's the environmental risk factors that I just mentioned, like the social determinants of health risk factors. We have many risk factors indexing conditions. We use the CCW definitions for these. We have risk factors that cover demographics. We have risk factors on pharmacy utilization, and we have risk factors on general health services utilization. So all told, there's about 200 to 220 risk factors in our pool of risk factors, depending on the model. Next slide, please. So the pre-AH model, the avoidable hospital events, this one, if you are familiar with the MD-PCP reporting suite, you'll be familiar with this risk score. And so this predicts inpatient admissions or ED visits for a preventable hospital event in the next month. So our definition of preventable comes from the AHRQ prevention quality indicators, and it's a composite of 10 different conditions which are deemed to be avoidable if there is primary care. And so we have about 200 risk factors that go into this model. And just like we said, there's about half of them are condition-based, and about 45 are utilization-based, and some pharmacy, and some demographic, and some environmental. Next slide, please. The pre-DC model, so the predictive model of severe type 2 diabetes events, it is built on top of the pre-AH model. And so it predicts a different outcome. So instead of avoidable hospital events, we are predicting an entirely separate event. And this event is inpatient admission or ED visit for severe type 2 diabetes complications in the next month. And notably, everyone is going to get a risk score. You don't have to have diabetes or an active diabetes diagnosis to get a risk score. The thinking behind that was we didn't want to miss anyone, basically. It's possible to have diabetes but not show up in the claims as such. And so everyone gets a pre-DC score, just like they get a pre-AH score. And like I mentioned, it's built on top of the pre-AH model, so it includes all of the same risk factors as pre-AH and about 18 additional risk factors that are we identified as in principle being especially predictive of this particular event. Next slide, please. And so at a very, very high level, this is the distribution of the populations that for whom we make these pre-AH and pre-DC risk scores. So we have about 750,000 Medicare fee-for-service individuals. It's about half and half for the MD-PCP and the non-MD-PCP population. And then we have a very large population for Maryland Medicaid. It's about 1.4 million. And this is it's the Health Choice Program, which is large, about 1.4 million. And we also do Medicaid fee for service, it's pretty small. It's about 50,000. So we wanted to include a few very high level summary stats about these populations that receive risk scores. We don't want to spend too long on these, but I think the key takeaway of this slide is there's a lot of people that now have risk scores available for them. It's over 2.1 million people. It's almost everyone in Maryland who is either on Medicaid or Medicare fee-for-service. They have risk scores available for them now. We can see at the bottom the average value of the risk score by score, so pre-AH and pre-DC for these populations. Now, these scores on average, they do look low, and these are pretty rare events, so it's not surprising that the average scores are low. The key, though, is that they're not low for everybody. Some people have a very high risk, 98%, 99%. And so with the predictive risks tools, now you're able to actually see that percentage probability that that person is predicted to have that event in the next month. Next slide, please. So we keep track of the performance of these risk scores very closely, and we wanted to include some information on that. And so how we measure it is we look at all people that receive a risk score for each of these different populations, and we line them up from most risky down to least risky according to our risk score. And then we look at, in the top 10% riskiest people that our risk scores are saying are the riskiest people, how many actually have one of these events? And so what we see is that the people that the risk scores say are risky are the ones that really are having these events within the next month. If we focus in on the top 10% riskiest folks for the pre-AH tool for the MD-PCP population, let's say, it's about half of the actual events that occur for everyone are focused on this top 10% number. And so we see that it's about that for all the other populations. Notably, the diabetes complication model in the health choice population performs extremely well, where about 85% of the actual diabetes events we're trying to predict occur in the top 10% riskiest slice for the health choice population. And so we have a lot of confidence in the predictive power of these risk scores. We look at the production performance in the training data while we're running the models, and we look at it in the actual data wherever possible. Next slide, please. So like Grace said earlier, it's not absolutely everyone who will receive a risk score. Of course, I mean, patients that don't have either Medicare fee-for-service or Medicaid, we don't know anything about them. We cannot make risk scores for them. Medicare Advantage, they do not receive risk scores, and Medicare or Medicaid partial benefit, they also do not receive risk scores, just because we don't have the complete picture of your utilization. Having said that, it's about 2.1 million people, so it really is the vast majority of publicly insured folks in Maryland. Next slide, please. And so, what we hope that you can get out of these risk scores is just a tested and trusted tool that can help you identify the folks that need help before they actually need that help. These have a focused outcome. We're not trying to predict spending. We're really trying to predict these laser focused events. These are timely. We release new risk scores every month using the most recent claims data. These are apples to apples. You can compare your Medicare and Medicaid populations, and you can actually compare them. The pre-AH score for someone on Medicare can be comparable to the pre-AH score for someone on Medicaid. And so we have a lot of confidence in these risk scores, and the feedback that we've gotten over the years is very strong. Next slide, please. So for more information, we have full technical documentation that's available. It's on Hilltop's website. It's on CRISP. There's an FAQ document. There are one-pagers. And but you could always reach out to Grace or reach out to myself or the Hilltop team, and we'd be very happy to answer any questions. Next slide, please. So, Grace, thank you very much. That's all I have. Thank you for having me on today.
Excellent. Thank you, Morgan. I will take over from here. My name is Audrey Speeder. I'm a vice president at H-Metrics, and we have partnered with CRISP to develop the multi-payer reporting suite. I hope this is not your first opportunity to see the reporting suite, but I am going to spend a few minutes now highlighting the prediction tool report and refreshing kind of the highlight of the quality dashboard. Next slide, please. So just a quick summary based on what Morgan just introduced to everybody. We have developed a prediction tool report, and it is based on Hilltop's risk scores that Morgan just walked you through. So we are presenting the scores for both the pre-AH model and the pre-DC model. So you'll have the opportunity to toggle between those two reports in the multi-payer reporting suite for the panels that you have available to you. It is a beneficiary level report, so it is not really rich on visualizations. What's most important is your ability to identify beneficiaries, identify their risk score, and understand their relative risk relative to other people on your panel. So we have conditional formatting. We have it hopefully in a user-friendly way so that you're able to see the individual scores. We also have additional beneficiary specific attributes to help you understand what's driving those risk scores. So to the extent that those are actionable to you in your practice, you're able to identify what's driving that and address that in your care management. Next slide, please. So this slide is mainly here for your reference once those slides become available to you. These are just two screenshots of the prediction tool reports, but I'm going to walk you through a live demonstration in just a few minutes, and we'll get to more details on that soon. Next, please. So next, when we get to the demonstration portion of this presentation, I'm going to walk you through the quality measure dashboard. There has been a complete webinar training on the quality measure dashboard already when those were released about October or so. So if you have not seen that full training, I welcome you to access that. A link to those to that webinar is on this slide once you receive those slides for your reference. We welcome you to go in, and it's about an hour presentation, and it is much more detailed than I'm going to provide you with today. But in a few minutes, I will just quickly rehash the quality measure dashboard, the way it works, the measures that we're including, as well as the health equity by demographics report as well. Next slide. Thank you. So on the quality measure dashboard, I do just want to take a second and highlight the types of measures that we are including in that report. There are effectively three different types of measures. So they're arrayed on two different domains. You have representing each row, you have a different unit of measure, and you have a different measure type. So going down the left column, you have a unit of measure that is a beneficiary. So that means that it is a beneficiary level quality score. So for example, does a given beneficiary have an asthma medication ratio of 0.5 or greater? Or does that beneficiary overall have a hemoglobin A1C score that is considered poor control? It is the unit of measure is the beneficiary, and we're presenting rates in that first quadrant. Separately, we have a unit of measure across several of our measures that are events. So these are not representing a beneficiary as a whole. These are representing discrete events in their healthcare system. So whether it be a follow-up after emergency department visit or a follow-up after hospitalization, we are looking to find that hospitalization or that emergency department visit and seeing if the beneficiary received follow-up for that specific event. So that's represented in our second type of quality measure. And third, we have simply count-based measures. These do not have thresholds. These do not have control totals or comparison groups. These are effectively counts of individual events. Okay, I am now going to take over your screen, Grace. Grace, can you confirm that you can see my screen?
Yes, I can see your screen.
Perfect, thank you. Okay, so you are now in a demo environment of the multi-payer reporting suite. Any information you see here is masked for PHI. It is all fictitious. There is no PHI on your screen. So I am in the multi-payer reporting suite. Again, I hope you're familiar with this and you've kind of acquainted yourself to the general flow. And I have gotten us directly to the prediction tools report. When you navigate to this prediction tool report, you are going to see the first filter that you have is you're able to toggle between the pre-AH and the pre-DC scores. The default is going to be the pre-AH, but you're able to toggle at any point to see the severe diabetes complication scores as well. We also have a filter for beneficiary name. So if you have worked through the prior reports in this suite and you've kind of honed in on a beneficiary that you have particular concern about, they either have a high rate of inpatient admissions, they have a lot of ED visits, they have high cost, high PQIs, and you want to understand what their risk score is specifically, you don't necessarily need to navigate this report and try to find them in your lists of thousands. You're able to type in their name directly right here or use the filter and pull up specifically that patient. Also in this report, we have a prediction score key. So I want to take a second and talk about our conditional formatting of how these reports are working. This report is showing you every beneficiary that is in your panel. So within your panel, even if you have a specific roster, you will have every beneficiary named here, and you have key demographics about them. So your Medicare and Medicaid ID number, if that links to any of your internal references, and simple demographics about them. We also have claim payment amount that gives you just an indication of overall healthcare utilization. And then this last column is their prediction score. You'll see that there's 5 different colors reflected. If I were to scroll a little more, you're going to get to 5 different colors. You have your top first percentile as those beneficiaries that have the highest risk score within your population. It is specifically the first percentile within your panel. So it is not comparing that risk score to anybody outside of your panel. It is specific to you within that panel. What is the patients who have the highest risk? You also then have the 2nd to 5th, 6th to 10th, 11th to 20th, or 21st to 100th percentile. So we're really highlighting effectively the top 20%. So you can very easily see red are those that are at the highest risk of those events, orange, still high risk but not the top, and it can kind of help you direct your care management resources to where you think you can be most actionable. If you want to filter so you don't have this whole list, you can use one of these drop downs or use one of these selects. It's a multi-select to isolate your list to just that population. Okay, so I want to reiterate something that Morgan described just a few minutes ago, and that's about the population that has risk scores. It is important, as he noted, that we have the complete claim data set available in order for risk scores to be, for Hilltop to be able to calculate those risk scores. So you're only going to find scores for those beneficiaries who are currently enrolled in Medicare fee-for-service, Medicaid fee-for-service, and Medicaid managed care beneficiaries. So it's important that they are currently enrolled. If there is a beneficiary on your panel that is recently deceased, or is a beneficiary on your panel who has dropped their Medicaid coverage and is no longer enrolled in Medicaid, they will not have a risk score. Um, Likewise, the Medicare beneficiaries are required to have both Part A and Part B claims. That is very important because if it is only a Part A beneficiary, then we do not have their ambulatory claims to indicate. So we'd be likely missing a lot of chronic conditions. We'd likely be missing a lot of, well, we would be missing a lot of utilization. So the risk score would not be accurate only based on the Medicare Part A or the institutional claims. So Hilltop excludes that population, as Morgan mentioned. So any beneficiary who does not meet these criteria are not going to be in this report. So if you do find that somebody is missing, it is likely due to one of these criteria. Also, the prediction scores are, like I said earlier, they are based specifically on your panel. If you do apply any roster, then those those bands are not going to recalculate. They are going to stay in the color band that they were when you represented your entire panel. Okay, so as a use case, if I identified a beneficiary that was of interest to me, and let's take the second beneficiary, for example, I'm seeing that they have a risk score of 71.29%. So they have a 71% likelihood of encountering a pre-AH or an avoidable hospitalization or ED visit over the next few months. That's a quite high risk, and I want to understand more about them. So you have the opportunity to click on that patient, and you're going to see a pop-up for reasons for risk. By accessing this reasons for risk drill through, you are going to be taken to another page. Excuse me one second. Let me see, I might have timed out of that. Let's see, so it's going to take you to a second page where you are going to be able to see those reasons for risk, and it's going to give you the contributing variables. There you go. Sorry about that. The reasons for risk are giving you the contributing variables that led to that risk score. So for example, this patient has a 71.27% risk score. It is made up of 4 categories that Morgan outlined: conditions, utilization measures, demographic categories, and pharmacy variables. And you can see on the right side the primary reasons for that. So you can see that the top driver, the top contributor of their risk score is their prior avoidable hospitalizations. That makes perfect sense. We have known in the literature that prior utilization is often a good indicator of future utilization. So this person has large prior avoidable hospitalizations that's suggesting they might have high future hospitalizations. Again, it is not the only variable by any means. They have risk related to asthma, to diabetes, to UTIs, to all of these utilization, condition, and pharmacy variables. So this is a good way to help you just understand what's driving that risk so that providers are able to say, what's actionable on my side? Where do I need to focus so that I am able to bring down that relative risk for those avoidable hospitalizations in the future? If you would like to download all of the reasons for risk, there is an Excel download functionality here where you're able to download all selected beneficiaries or all beneficiaries overall. And those downloads are going to include all of the details from the prior screen. You'll be able to get their actually this will just be a full list of all the beneficiaries in these scores. And then the selected beneficiaries would be anybody on your roster or anybody that you are currently viewing on this screen. So if you want to be able to do some manipulation in-house and kind of work it through as Excel and do additional filters, maybe you want to provide additional filters by age or by race or by county, you have those exports available so you're able to do so. Okay, I think that covers a prediction tool walkthrough. I am now going to jump over to the quality measure dashboard. And as I noted before, the quality measure dashboard does have a full training available online, and Grace will make sure that that's accessible to everyone. That was a 1-hour training that walked through each of these reports in pretty good detail and how it works. I'm going to summarize this in about 5 to 10 minutes or so it'll be at a much higher level. So the quality measure dashboard was developed and released a few months ago, and the concentration was to make standardized quality measures available so that you're able to look at your Medicare or Medicaid population, their measure performance relative to a comparison group. So on the quality measure dashboard, you're going to see a global filter here for what your comparison group is going to be. It needs to be Medicare or Medicaid. And what's important is that your global filter on the top of your screen is pulling in the comparable population. So you should make sure that you are not running your panel on a Medicare population if your comparison group is Medicaid. It would just give you an inaccurate interpretation of your performance. So right now I am viewing my Medicaid population just for sample size. I'm looking at about 13,000 beneficiaries. And I'm comparing it to the statewide overall Medicaid population. This is managed care as well as fee for service. This landing page is providing you with effectively a snapshot. You don't have to go report by report. You're able to quickly see how is my population faring relative to the overall Medicaid population. And we have arrayed these reports based on the measure types that I outlined a few minutes ago. So you have your rate-based beneficiary measures. So these are looking at a beneficiary overall as a whole over the time period, how they're faring in terms of asthma medication ratio, hemoglobin poor control, controlling high blood pressure, and then we have 2 MDH specific measures looking at ambulatory care for SSI children and SSI adults. The blue bar reflects your panel, the orange bar reflects the comparison group of the Medicaid population. Your rate-based events, you do have a date slider if you want to isolate a certain date range. But again, we're looking at all of those individual services, those events, and looking at whether they had follow-up or if they had an actionable event. So we're focusing on 30-day follow-up after emergency department visit for alcohol or drug abuse. Same for mental illness, an initiation and engagement of alcohol or other drug abuse or dependence treatment, as well as prenatal postpartum care, timeliness of postpartum care, and timeliness of prenatal care. If you're familiar with the suite, these prenatal and postpartum measures are also accessible through the maternal health card. One more tidbit, if you are looking at a Medicare population, these two measures, the first one and the third, will not have information available due to the redaction of 42 CFR Part 2 services. Effectively, we do not have substance use services in the Medicare claim, so we will not be calculating performance measurement for them. And at the bottom, we have our count-based measures. Again, no comparison available, no control total. It's effectively just a count of those services. Okay, so I'm going to click through just 2 or 3 of these reports. Each of the each of the measure types have a very similar feel. So once you get a handle for one of them, you should be able to navigate seamlessly through the other measures within that measure type. So I've selected asthma medication ratio. This measure specifically looks at the percent of the population that has an asthma medication ratio of greater than 0.5. And a description of the measure is always available at the top of the screen. And there is a little icon to help you understand more about that measure and get additional information. So the report starts by presenting the asthma medication ratio for your population for those that did not meet the measure, less than 0.5, and those who met the measure, greater than 0.5, by chronic condition. So you can see here, while the numbers are very small, I think the intent is still pretty clear. You can see that the beneficiaries that have heart failure on this panel, 33% of them do not have the appropriate asthma medication ratio. So this enables providers to not only just look at the overall numbers, but be able to make it a little more actionable and say, what are the chronic conditions that are kind of driving this, and producing opportunity for additional follow-up within subpopulations to make it a little more manageable. On the right side, we also have the overall asthma medication ratio. This demo panel is doing pretty great. 95.5% have the appropriate asthma medication ratio. And if I wanted to understand who is meeting the measure versus who is not meeting the measure, you have a drill through here to get this beneficiary list. So by clicking on that, if I want to know who is not meeting that measure, I can go ahead and click here. It'll take me over to my population navigator window, and it is going to only include, I think it's about 15 beneficiaries on my panel who do not have, who have not met the asthma medication ratio of 0.05. You can either create a roster for this population, or you can kind of save and export and drill down to them more specifically. The roster functionality is pretty important here. If you find that you want to know more about these specific patients, you can create a roster, then you can look at any of their other utilization through the reports. Check out their acute care hospital setting, their acute care hospital utilization, their emergency, emergent or non-emergent ED use, PQIs, readmissions, really anything else once you create those rosters. All right, so this is going to jump me back to the landing page. And I can show you very briefly the bottom of the report. At the bottom of each of these reports, it's going to show you the disparities across your demographic categories. So you can look at the asthma medication ratio by race and by age and by gender. And all of these have drill through, so you're able to get to that subpopulation if you want to understand specifically who those patients are. Okay. So next, I want to show you very briefly the 30-day follow-up after hospitalization measure. Again, same functionality. The only difference I want to highlight here is that instead of a bar chart by chronic condition, you're looking at trends over time. Since this is an event-based measure, you're able to see how has your follow-up changed, and are you kind of on the upswing of providing more follow-up for patients that have had a hospitalization for mental illness. And we array the information by diagnosis and by age and gender, and you're able to isolate the people that have received follow-up in the light blue and those who have not received follow-up in the dark blue. Same for the demographics. The last report I want to show you is just a simple count measure. I'm going to show you the ambulatory care emergency department ED visit. As I've said before, no comparison group. These are just counts. So it's a good way to track not only the count of emergency department visits, but your distribution by hospital, your distribution by emergency room diagnosis or the primary diagnosis, as well as looking at counts by beneficiary. So this is helpful if you want to kind of identify those frequent flyers, those beneficiaries that have more than one emergency department or more than 5 emergency department visits. You'll see in this demo data for the date range I have here, which is quite large, we do have, I have 4 people that have 22 emergency department visits. You are able to, let me pick one that has a bigger sample so I can click it better. You can select those beneficiary details. It takes you back to the the population navigator, and you can see specifically who those are. That is to help you facilitate any care management or any other additional services and kind of reach out and touch those beneficiaries to see if we can avoid those emergency department visits in the future. Okay. In the last minute or two, I want to make sure we leave ample time for questions. I want to take you over to the Health Equity by Demographic report. There is a separate Health Equity by Demographic report in the base suite. The base suite or the base report is covering those demographics or those health equity distributions for all of the prior reports. It's looking at inpatient admissions per K, emergency departments, readmissions, all of that. This one is specific to the quality measures. So if you don't want to go report by report and understand where your disparities are, you have an opportunity to highlight those disparities in this report here. So it is, I have it now showing my AMR, my asthma medication ratio, and what's showing right here is the distribution of the AMR by age category. You'll see I have a drop down here or a selection here where I'm able to array these data any way I'd like. This is showing me by age group. I'm also able to array that information by race, and I want to be able to see if there's any disparities by race that are appearing in the data. And I can see, yep, okay, my Black population is 0.76. It is lower than my Asian, lower than my Hispanic, lower than all of the others. So it's something that's just drawing your attention to a disparity by race. You can also look at it by dual status for your dual eligibles of Medicare and Medicaid. Separately, if you want to be able to look at more than one demographic category at a time, you have the opportunity of adding an additional chart. So for example, if I want to look at my age, oops, wrong one. If I want to look at my age group by gender, it seems to have frozen on me. You would be able to, let's just refresh and see if that fixes it. You'd be able to look at both the gender and the age. So you'd be looking at, gender and age. So you'd be able to look at your over 65 population for males separately from your over 65 population for females. Let's see if that's going to pull up for us. Okay. So what we are showing here is you are able to see the overall measure rate for those age categories, and we also have a disparity index. The disparity index is effectively showing against a base population that has already been defined, how is each age group faring compared to that? So on the age metric, our 61 to 64 population is our base. So all other measure rates are divided by that race. Are divided by that category. So this is able to help you indicate how far off from that base any category is. So for example, our less than 18 population, they have a measure rate of 0.98. 0.98 divided by 0.92 is giving you that disparity index of 1.07. And here higher numbers are favorable because the higher the measure rate, the better. And last, at the bottom of this report, we are showing the chronic conditions by age with their AMR, with their asthma medication ratio. So you're able to see how many people fall within each of these cells and what their asthma medication ratio is. Okay, I think with that, Grace, I'm going to turn it over to you. Just a reminder again, if you'd like more details about the quality dashboard, please take a look at that training link. There's also additional resources and a user guide available in the suite. And if there's any questions at any point while you're working through the reports, please feel free to reach out to Chris, and we'll make sure to help you.
Thank you, Audrey. So we have 15 minutes for some questions. If you have any questions, feel free to put it in the questions and answer box in the Zoom menu in the bottom. I will be handing it off to Josh from the CRIS program administration CRIS program administration team, and he will read off some questions, and hopefully one of us will be able to answer.
Thanks, Grace. So the first question, and I think this question is from Morgan, is what version of AHRQ-QI is being used, and how and when are future versions incorporated?
Yeah, good question. So for the scores that are going to be released with a release date of this coming Friday, it uses the 2024 AHRQ PQI. These do get updated typically once a year, typically in July. We very much keep on track of it. We align with H metrics, so things are consistent across the various reports that use these metrics. So I would say there's typically annual or even slightly more frequent than that. The good news is that it doesn't really tend to change that much. It's typically like a diagnosis code will be added to one particular definition, that kind of thing. But long story short, we use the most recent available, and we update our scores to be consistent with it once a year or more frequently.
Thanks, Morgan. And another question is, how timely are these risk scores? And
Yeah,
like,
so
how recent are the data that run on?
yes, so as recent as possible. Of course, we're dealing with claims here, so there's always a lag. For example, the scores that are about to be released a week from today, they are run on the most recent cohorts of Medicare fee-for-service and Medicaid claims that we have, which contains information from January 2025. So it's as recent as we can get. And all of our risk factors are backward looking. And so, yes, of course, there's issues of run out with claims, but we designed this model to work on claims, and so it captures the new information, but it isn't dependent on there being complete new information, if that makes sense. So long story short, the most recent information possible and updated monthly.
There's a question about, are there any other insurance plans excluded? I'm not sure what that is in reference to, but maybe we just want to go over what data is included in the reports. That might help answer the question.
Yeah, so there we go. Yeah, that's perfect. Yeah, so if you are on Medicare fee-for-service with parts A and B, so you need to have A and B to get a risk score. If you only have, let's say, A, that means we don't have a full picture of that particular person's utilization and their claims and medical history, and so we just can't make risk scores for that person. So gotta have Medicare fee-for-service A and B. And then Medicaid, so either Health Choice, so the managed care program, it's like 85% of people on Medicaid are in the managed care Health Choice program, or you can be non-Health Choice Medicaid, but it has to be full benefit because of that same issue. If it's limited benefit, so let's say family planning only or something like that, then we don't see that person's full picture of their claims history, so we can't make risk scores for them. So Medicare fee-for-service with A and B, Medicaid, either managed care or fee-for-service full benefit. If there's a dually eligible person, we do make scores for them. They're included in the Medicare population.
Thank you. There was a question about, when are these reports available in CRISP, and are there future plans to expand to commercial data?
So they're live. They're up there. In terms of future plans, nothing concrete that I know of. We're always hopeful. These scores, they have been expanding. We started with the MD-PCP Medicare fee-for-service population. And so that's about, first it was 200,000, then it was about 350,000, and now this kind of quantum leap. And so no concrete plans for expanding into commercially insured, but very, very much open to it. If the claims are there, we can do it.
Okay. We have a question. For the inverse metric on HbA1c poor control, are the rates looking at populations in control?
So what we actually present for the poor control measure is we provide each of the bands. So poor control is defined in greater than 9. We define we provide the meeting the measure and not meeting the measure. So you're able to actually look at the inverse. So I know that there's the inverse measure of poor control or control, and you're able to use the report to look at it from either direction.
Thank you. A comment, understanding that the quality measure types, but what is the data source for these measures? Is it claims based only from CPT and CPT2 codes?
Yeah, that's a great question. So we are using only claim-based measures. So we are not augmenting the measures with any clinical data. So what I kind of glossed over today, which is in the broader training, is that for the hemoglobin pore control and for the controlling blood pressure measure, those really kind of thrive the best when looking at clinical data because you have the labs to then indicate what the HbA1c score is and what the blood pressure is. Since we are doing it from claims data, we are really reliant on the billing of the HbA1c and of the blood pressure, not the billing of doing the test, but the billing of the results. So you're going to see in those measures, you're going to have about 95% out of compliance. So 95% of your population not meeting the measure, specifically in a Medicare population. Medicaid fares a little better, but that's actually a billing anomaly. That is not a clinical anomaly. So what we're hoping is that over time, when there's more of an emphasis on actually getting those HbA1c and blood pressure results into the claim, that those rates will kind of come down and get more in line with clinically what you're seeing. So we're kind of hoping it's an opportunity that people say, this is really helpful. I want to be able to have a more clinically appropriate assessment. So by getting those into the provider claims, we're able to pull them in. So again, this is administrative measure only, and it does not include the clinical measures from the LOINCs or the other lab results.
Thanks. What does emission from the community mean? Is it ambulatory provider or another similar type of provider?
Oh, I think you're referring to the first measure, admission to an institution from the community. Um, if I'm understanding your question correctly, that is an admission, that is a community-based beneficiary that is then hospitalized. So it's a beneficiary that's residing at home that is then going into a hospital. It is not reflecting a population that, let's say there's a beneficiary in a SNF or in a long-term care facility or an otherwise kind of institutionalized setting that is then getting admitted to a hospital. So the beneficiary is residing in the ambulatory space or at home and is then getting a hospitalization from there.
A question about how often are the models retrained? Might be for Morgan.
Yes, good question. Retrained quarterly. So every single model retrained every 3 months. We actually run 4 separate models per model to account for differing amounts of people with different claims run out, or excuse me, claims durations or environmental risk factor availability. So long story short, every 3 months, we keep a very close eye on, do the coefficients look stable over time? Yes, they look stable over time. Way back when, during COVID times, we retrained every month just to make sure we were keeping on top of any rapidly shifting kind of features of the health landscape. But we reverted back to the quarterly training cadence a couple of years ago.
Do the risk scores take risk adjustments for HCCs into consideration for diagnosis? If so, how is the blended conversion from V24 to V28 factored in?
Yes, so these are not at all linked to or related to HCCs. We don't use the HCCs at all in the creation of our risk scores. Everything is in our full technical documentation, risk factors, coefficients, model performances, for anyone interested in really getting into the nitty-gritties. Again, we have about 200 risk factors per model. About half of these are based on are condition-based risk factors. So does a person have a history of heart failure? Based on the ICD-10 diagnosis codes in claims within a certain look-back period from certain different kind of claims, professional, institutional, pharmacy, and so on and so on. And so we try to be very transparent and very open with the details of our model. So anyone interested in technical questions should certainly consult the documentation. But yes, long story short, we don't. They are in no way related to HCCs, and so it's not factored in.
Great. I think There's just one last question, unless anyone else has any other questions they want to put in. It's just about how to access the quality measure dashboard.
Sure, I can take that. That is a reporting suite that's a report that's available to everybody who has access to the multi-payer reporting suite. So you'll see it actually, Grace, if you can scroll up to I think maybe one of your first or second slides. Oh, actually, it was probably on my first slide. There it is. That's going to be at the very bottom of your left menu. So when you enter, there.
Oh, all right. I'll go to your slides first.
Okay.
I was gonna go back to the my slide on how to access the
Yeah,
report.
there
Here
you
we
go. Wait, if you go back up, there you go. So this is your left menu. You're going to see the prediction tools is the one that's just highlighted here because that's the slide we're on. Right below it, there is a separate box for quality measure dashboard. It contains the dashboard and the health equity by demographics quality report. I do want to add just one thing. I know there was a question, Grace, that you answered by text about the data freshness for data weekly, is it daily, weekly, monthly? The data itself is updated monthly. So we have a monthly refresh. It is generally the second Friday. Grace gave you the more technical answer. It's generally the second Friday of each month. It's really the first Friday of the first Friday of the first full week of the month. Just to make that more confusing for you, the next refresh will be next Friday on March 7th. April will be April 11th. So those are updated monthly, but any changes to your panels are refreshed weekly. So if you go ahead and you make a change to your panel on one day, within 1 week of that, I think it's refreshed on Friday, I can confirm, your panel will be updated with a new population. Just the data is only updated monthly.
All right. Are there any other last minute questions?
I do not see any in the chat.
All right. If not, thank you everyone for joining today. We will be sending out the slides and the recording after this. And please feel free to reach out if you have any additional questions or feedback, or if you need any help getting access to the report. Thank you so much.